Good morning. Welcome back for the third and final day of the Practicum. Great turnout. Thank you very much. So, as Reagan mentioned, I am with the ODS, and I've been with the office quite a long time. I won't say how long, doing various roles and responsibilities. So, it's a wonderful culmination to see the Practicum every year. Our first speaker, and will be the last speaker on our scientific series presentation, so to speak, is Dr. Johanna Dwyer, who is a senior nutrition scientist with the Office of ODS. And she also is from Tufts Medical Center, where she serves as the director of the Francis Stern Nutrition Center at the Medical Center. She is professor of medicine and community health at Tufts University School of Medicine, and also the Friedman School of Nutrition Science and Policy at Tufts, as well as senior scientist at the Jean Mayer USDA Research Center. So please welcome Dr. Dwyer, and she's going to talk to us about why Americans use dietary supplements, and she's been looking at this issue for quite a long time and has really delved deeply into it. Dr. Dwyer?
I hear this is a great group, and I know a little about it because I got to go to your reception on Wednesday night, and it was a lot of fun. Let's just start with a few questions. One is why people use supplements. Does it really matter to even think about it? How to find out about it. For those of you who do research, this may be interesting. What causes supplement use? How motivations differ from one group to another, and finally, what are the practice implications? And I'll try to draw on some things you've already learned, I think, in this practicum as we go through this talk. But first, let's just talk, why even bother to think about it or talk about it? I think supplements are important, the motivations are important for a number of reasons, because they reveal things that otherwise I don't think we'd know very well. First of all, how people use them for dealing with health problems. And secondly, just exactly what the teachable moments are that encourage or discourage use. For example, for women who are in the periconceptional period, you'd certainly want to be sure to make sure that you know exactly when it is that they should be encouraged to use folic acid supplements. I just read a paper, I think Dr. Coates and I both read the paper, of a group in another country where they really weren't, the women were using the supplements, but they were using them later in pregnancy, and that doesn't do any good for neural tube defects. And then finally, warning signs identifying people who might be at high risk of inappropriate use. And I'll talk a little bit about that, whether they're ill or whether they have drug interactions or toxicities, whatever. Okay, so that's why I think it's worth spending a little time talking about this business of motivations. Let's now turn to the issue for those of you who are doing research. How do you really study this? Well, the simplest thing, and the thing that first occurred to me when I came to the office was, well, let's look up and see what people buy. And what people buy is probably, you can tell what they're doing by what they're buying. A second way is surveys. A third is focus groups and cognitive interviews. Let's talk first about supplement sales, because they're a little disappointing. There's some possibilities here. Have you heard about Nutrition Business Journal already? If you haven't, that's a good thing to know about. It's a trade publication, but it does have lists of sales by different categories of supplements. And in a sense, in some respects, you can infer motivations indirectly from these data. A second thing that's a pro is that you can get some idea of what consumers are willing to pay for, because the sales have the money listed, of course. but they do reflect only price. They don't reflect prevalence of use. For example, if you go into a CVS or a Walgreens, you can get a generic or a house brand multivitamin mineral supplement, and it's relatively reasonable in cost, doesn't cost very much. Some of the more boutique supplements cost a lot of money, and so you can't tell from money alone what the prevalence of use is. And some of these condition-specific supplements I'm going to be talking about in a minute are really rather expensive. And for some people, this can amount to a fair amount of their paychecks. There are also poor associations with prevalence of use, and you have to infer the motivations from the marketing pitches. For example, a performance enhancer, well, people would be using that for a variety of things, and you really don't know if that's what they're doing it for, or if they just like the taste of the energy drink. Okay, let's go on and think a little bit about surveys, because I think those are really the best thing of all that I've found, at least for doing this. And thanks to the Office of Dietary Supplements and colleagues at the National Center for Health Statistics and NHANES, the National Health and Nutrition Examination Survey now has a lot of information on motivations. The other group that also has some information on motivations is the National Center for Complementary and Alternative Medicines supplement to the National Health Interview Survey. This is more periodic, and so it's something you have to watch for and use only every 5 years or so. A second group of surveys that I think are also useful are commercial surveys that are fairly representative samples of the U.S. population. And then third are small surveys of special user or prescriber populations. And I think Patty Doyster spoke to you yesterday about some of the things that the military's been doing. They've done some really nice surveys. I'll show you one slide of that in a moment. So let's talk about NHANES, because NHANES really gives us a picture of what free living adults in the and children in the United States are doing. It's got so much, it's such a rich data source. You can associate motivations, which they now ask for thanks to the collaborative efforts of NCHS and ODS. We can ask now about supplement use, intakes, diseases and conditions, and motivations, and so you can link one to the other. We can also link motivations and use with blood, body composition, and clinical findings. So it's not just reported kidney disease or heart disease or whatever, it's also actual findings on physicals. And the beauty of all of this is it's population-based, and it's representative of the ambulatory non-institutionalized population. Now, there are some negatives as well, though. One is that it takes a couple of years to get the data because they have to aggregate the data to preserve anonymity. Response rates in any kind of survey, particularly in-person surveys, are falling throughout the country. It's just a terrible problem for those of us who care about representative samples. NHANES, of course, is cross-sectional, and so causal inference is limited. Finally, it includes nutrient supplements and the amounts of them, but for other supplements, non-nutrient supplements, it doesn't necessarily have exact amounts. It still remains, I think, the single best source of information, and I'll show you some data on that in a minute. The NHIS survey is population-based as well. It's a different sampling frame, and it's a very large survey. So the estimates, the prevalence estimates, particularly for things that are only used a little bit, are better than they are in NHANES, because NHANES is what, 5,000, 10,000 a year. And this is much, much bigger. The problem is that it's pretty much supplement categories like multivites, single vitamin minerals, and so forth. and it doesn't have amounts of supplements. So it tells you they're using it, but it doesn't tell you how much. NHANES tells you how much. And many of the questions on the survey don't deal with supplements, but they deal with complementary and alternative medicine. And for those who like to take a look at that, which is a whole separate field of research, you can get motivations for supplement use and then combine them with studies of CAM. So those are all good things. The other thing is it's periodic, 2002, 2007, 2012, and there were some early surveys that also included some information on supplements, but it isn't continuous the way NHANES is. Some of the other issues here are, first of all, there are no health measures. NHANES is very rich in terms of the health measures, the general health status. Not in this study. There are no outcomes. You can't link it to mortality the way you can with NHANES. There are no dietary intakes, so you can't calculate total nutrient intakes the way you can in NHANES. And they're categories only. So there are a lot of problems with this. But still, it has a lot of use for some of the less commonly used supplements. And here's one example. This is from NHIS 2012. It's a way to get at some of the less popular products. You see here, 2012 is in red, and then 2007 is in blue. And what you see is they bounce around a little bit, but they're pretty consistent. The fish oil's going up, but all non-vitamin, non-mineral supplements stay pretty much the same. So for those less highly used supplements, this is a good survey to take a look at prevalence estimates in. Let me go on now to commercial surveys, and I'll just focus on one. There are a couple of others. Pew occasionally does surveys, and a number of other national groups like Gallup also sometimes put in questions. But Natural Marketing Institute is the one that is probably in the field the most. These folks do surveys. The surveys generally tend to be about natural medicine and natural marketing sorts of things, organics and so forth. They have done these surveys now for about 20 or more years, and so they have limited trend data that are available both on use and on motivations. One advantage for those of you who are in private industry is that you can submit a question or buy it. You have to buy them, but you can buy an item on the survey, say in January, have them do the survey because they do it every spring, I think, and by the fall you'll have the answer. And so that's a big thing if you're in a company where you're trying to think about motivations and trying to connect it with something you're selling. And also, they sometimes ask questions about rarely used supplements that the big national surveys don't, because they're more interested in the prevalence estimates for what people commonly use. There's some other things about those surveys you should know before you go and buy them. One is that it's pay to play, so you will have to pay. They're not public use the way the big national surveys are. The questionnaire, I shouldn't say poor, but it really is. When we tried to use it a number of years ago here in the office, the items are often not well worded, and so there's a possibility of a yay-saying bias or misinterpretation. There's also very, very little dietary data. There's almost nothing on physical measures or outcomes. It's just what people say. That they have a heart disease or whatever. So the samples may be problematic from another respect as well, and that is that they're not representative. They may oversample users. And because the format is often just web-based rather than in-person interviews, they may not reach people who are computer illiterate. And this is a problem if you're thinking of people who are very old and sick, for example. That's going to be a very difficult group to get to use computers for the first time to take a survey. Nevertheless, we've used these surveys with some some success for some limited purposes. Now, the special surveys, you've probably heard a number of these now. There have been a number of surveys of warfighters, and I really respect the work that people at the University of the Health Sciences and also people up in Natick are doing on this with warfighters. Cancer survivors are another group that have been studied extensively, and I'll show you a couple of slides on them. And then HIV patients, who are interesting from another standpoint because HIV is almost like accelerated aging in some respects. So for studying frailty and things like that, they're very interesting. Prescribers, lots of studies of these, physicians, pharmacists, nurses, and dietitians. And there have been a couple of surveys on them. Sometimes the sampling frames are not, the sampling is, the frame is okay. The problem is the response rates are very low, like 1% or 2%. So they're not, they can't get a representative, or they can't predict what people are going to actually be doing in those professions. But some of the positives about these surveys are, first of all, that they help to document and explain behaviors of subgroups of special interest or people who are at special risk of harms. I take HIV patients as one example for that because they're taking a lot of drugs that may in fact interact with the dietary supplements and cause some problems. The other thing about these special surveys that is particularly useful is that it provides insights in terms of influencing users or crafting interventions. For example, if you find that people think that there's no harm in taking a dietary supplement along with their treatment for a particular disease, they may be wrong, and you want to know about that, and you want to be able to deal with that. So that's some of the pros. The cons are that very often these surveys don't test their items very well. And I recommend, if you're thinking of doing a special survey, to take the items from the national surveys, which have been carefully tested, and just use them. They're public use, so there's no problem of copyrights, and it really is very helpful. And they're not necessarily representative. Now, one of the reasons why I say to take those items is because the National Center for Health Statistics uses focus groups to test the survey questions that they're using to make sure that they mean the same thing to respondents as they do to the people who made the question. And so that's why I say these items are worth copying and using in your surveys when they get at the points you want to get at. The nice thing about cognitive interviews is that they also give you a sort of reality bath, if you will, in why people are using various things. And it's really very nuanced, and you get an idea of the thinking and logic that people have. For instance, if you take a bunch of athletes and just sit them down and get them to tell why they're using them, or people who are in some specific disease category. The problem with focus group interviews and cognitive interviews, if any of you have ever had to listen to a tape of one of these things, they go on for like 2 days, and it's very expensive in your time and your ear time, if you will, but also getting the focus groups together, getting a good moderator who really knows how to ask probing questions without leading the respondents is not easy. The groups that are selected may not be representative, so you're getting a skewed view of, say, hockey players or whatever you're looking at. The interviewer has to be well trained, and the analysis also needs to be done carefully, and because it's qualitative and subjective, interpretation is also quite subjective, and there are cognitive psychologists who do this for a living, and they're very good. The ones at NCHS are really quite good. So I think we can trust those items. Other items, not so good. Okay, so that's some of the ways we can get at these things, and I'll show you some examples in a few minutes. Now let's go to the thorny question. That is, supplement users and how they differ from non-users. And I know you've heard this before, that they do differ from a number of speakers. There are lots of reasons. Certainly, you've already heard, I hate this mouse, it doesn't behave itself. The demographic reasons you probably already heard, and they're clear in NHANES, for example, that people differ by supplement use in all of those ways. The attitudes are a little hard to get at, and we're just beginning to explore them in NHANES and elsewhere, but attitudes clearly influence this issue of motivations and also use. Well, the motivations vary a lot. Some are easy to articulate. If you listen to focus groups, they'll talk about overall health and disease and performance, whether it's athletics, performance in the bedroom, or appearance, things like weight loss. Those are pretty easy to articulate. But then there's some other reasons that are harder for people to identify and really articulate. One is because someone they trust told them to take it. It's easy if it's a doctor probably, but it's not as easy to get at some of these other social influences. And also it's hard for people who are taking supplements as part of their whole worldview, and this is true especially with botanicals and herbals, to get it, to try to really isolate why they're doing it. So there are many different reasons for use, and I think the fundamental take-home message here is that it's not just for what the law says, which is to supplement the diet. That's what the law says. There are many, many other reasons to prevent and treat disease and for all of these other things. So let me look now at some work, and actually Reagan Bailey led this work on motivations for supplement use in using NHANES. And what you see here is that there are a whole bunch of different reasons why people, these are adults in NHANES a couple of years ago, and you see the improve health, maintain health, prevent health problems, and then the supplement the diet, which is the legal definition. But you also see a whole bunch of other things, including bone health, and we'll come back to that in a minute. There are a whole bunch of things that we need to think about. One is the authority-based use, where people are operating in a deliberate and purpose-driven manner, and they're doing what the doctor said. For instance, the doctor said, take a prenatal and I'm pregnant. I'm not pregnant. Take calcium and vitamin D because I might have a bone problem. That might be true. Mothers knows best, all of these things. But the problem is, who do you consider an authority and what do you really consider evidence? And that isn't always easy to see. But here's an interesting thing. This was put together, I think, by Jamie Geisch in our office. What you see, look at the red line there. The red line is interesting because if you remember the literature, starting in the early 2000s, there were a lot of reports in the medical literature about vitamin D. And a lot of physicians started telling people to take vitamin D supplements, and look at, it did go up. So often physician recommendations will influence use. There's also the other kind of social influences where people become, they use something and then they adopt reasons for, they use something because of their friends using it or somebody else using it, and then they find reasons to rationalize their behavior. And then there's some people who have a worldview that often involves use of supplements and many other behaviors as well. And it may even be quasi-philosophical or religious beliefs or cultural beliefs that have use of certain supplements deeply embedded in them. And there are also the copycats, the people who think that the health outcomes of users, say athletes or something, are due to the supplements they're taking and not to their other characteristics. And this is a very common mistake that people make when they first get studying supplements. For instance, you want better performance, you see this guy has great performance, you assume that it's due to the supplements, And so you start taking the supplements yourself, and if I use it, I'll win too. Well, it doesn't happen quite that way. Let's turn now to the condition-specific supplements that are disease or illness-based. And these can be due to either a disease or to some other condition, for instance, a situational factor like illness or combat that influences use. And whether or not, very often with these conditions, health conditions, people think of them, the supplements, as maybe they're going to help. And they certainly can't do any harm because they're on the market. So why would anybody sell things that are harmful? And so it's common for people with conditions like HIV, advanced cancer, migraines, things that are difficult to treat or we don't have good treatments for. It's also, there's a very small group of people, but there are some people who are convinced that conventional medicine is just a way of getting money for doctors, and that supplements are an alternative that doesn't involve that. I think that's very small. I think most people are simply assuming that there may be some good coming from these, there isn't any harm. Here are some examples. If you look at eye health up at the top, at fiber and bowel health, omega-3s, and heart health, you see how people are connecting specific supplements with specific conditions. Whether they're efficacious or not, though, is another matter entirely. So the motivations may be appropriate, but the question is whether the efficacy is there for the supplements. And if we look at national health and the NHANES survey, you see that treating a condition is really, in the red, is really quite a sizable bunch of the motivations that people have, especially for the natural products that are non-vitamin, non-mineral supplements. And then, of course, any other wellness reason also comes up in there, too. So a little confusing, but to me, the most puzzling thing is what do people consider real facts and fake facts? And of course, I'm not alone in this confusion. I see it in the Washington Post every day. But what people consider facts may not be scientific evidence of the type that you've heard people talking about from our fact sheets and from the U.S. Preventive Health Services Task Force. There are a whole bunch of other alternative things that people think of as facts, or at least some people do, that really aren't. Well, I won't go too much into motivations theories because there are a lot of them, but I'll just list a couple. One is the notion that that the supplement will give you a license to engage in unhealthy behaviors without having any harm. Sort of a Superman idea that these are protective and that you can get these health benefits and they'll protect you against anything. Another theory that some people have explored is the whole notion of readiness to change, to try to explain why people use certain supplements like multivitamin mineral supplements, whereas herbals are not really considered relevant by most people, and so they're not ready to change and start using them. And Prohaska's theories have been used there a lot. The inverse supplement hypothesis is basically trying to explain why it is that supplement users are often those who need them the least. And the fact that supplements are a marker for a range of positive health behaviors I think you know about from previous talks. But what is interesting is when you get to certain groups, for instance, the very old and sick, this may not be true. They may be sicker rather than healthier. So you have to look at everything. Let's just turn, as we wind up, to some looks at these subgroups. And here's one that we've become very much interested in. And Marion Newhauser out at the University of Washington in Seattle has done some wonderful studies on. But this is a different study by John et al. In the Journal of Cancer Survivors. On cancer survivors, they're high users of CAM. They spend about 7%, they're only about 7% of the population, but they spend like 11% of out-of-pocket costs on CAM and vitamin mineral supplements. And what you see in red here is the cancer-free patients in this survey, and then the cancer survivors are in blue. And what you see, whether it's down here at the bottom, at least one vitamin mineral supplement or CAM, the differences are really quite profound between the survivors and people who are cancer-free in all of these categories. And so they're a high, it's up around 80% of these folks are using things. There's also the issue of certain diseases and conditions where we don't have a cure. And somebody said once that when there's no cure, there are 1,000 treatments, and this is certainly true for things like autism and a whole bunch of other things. And here's just one slide. This is advanced melanoma patients, and you see here again that they use 41% of them, these patients are using some kind of dietary supplement or complementary and alternative medicine. At least 25% of these use supplements and other biologically based therapies. They use them up around a very large number. The people who are really satisfied in the dark blue are far less. Why do they use them? Back to the motivations. They're not using them so much as a cure as they are for doing something to try to fight the disease, strengthening the immune system to try to lengthen their quality of life and to strengthen their own forces. So they're trying, where we don't have good treatments that are going to be curative, to do something at least. Another group is the older Americans, and if you just look at the blue lines there, you see that older Americans use a lot of dietary supplements, both for general and health-specific reasons. Here's bone health, for example. This is a study I think, Reagan, you did. And what we see also is that older Americans with illnesses involving functional impairments use a lot more of the condition-specific supplements. Over on your left is the history of arthritis and use of glucosamine and chondroitin sulfate, and you see that the patients who had arthritis use a lot more of them. And over on your right, you see people with a history of osteoporosis or fracture use a lot more vitamin D and also a lot more calcium. Supplement use also in these elderly people seems to increase with use of prescription medications. So these are not the healthiest people. They're sometimes the sickest people. These are people over 60, 65, and you see it goes up. Soldiers you've already heard about. They're using different kinds of supplements. They use protein powders and bodybuilding supplements, especially in the combat zones. The blue bars are people who are deployed. They're in places like Afghanistan or Iraq. And the garrison, the people who are waiting to go, use a little bit less, but they all use up around 80% of these products. So it's huge compared to the average American. Well, let me wind up just with some implications. First of all, for Pete's sake, if you're in clinical practice, ask about supplement use. We know that people don't tell the doctor unless the doctor asks. If you look at the bottom of that slide, the people who say that the doctor never asked, and that's the reason I didn't tell him about it, is the main reason why the doctor didn't find out. There are a lot of other reasons as well, but that's the main one, and therefore we urge you to ask about supplement use, and then take the time to talk, especially with those who are at high risk. The people who are using supplements to delay or instead of effective treatments because we have something that can help. Polypharmacy with many meds, like that slide I showed you with the elderly, because of the risks of interactions. Chronic illnesses with poor prognoses and many medications because of interactions and also because they need to have someone listening to them because they've got a lot of health problems. Medications with side effects, and then the ineffective therapies where we don't have much to offer. So the bottom line is ask about what's used and why. We know that people are using supplements for purposes other than supplementing the diet. Most realize that they can't treat disease alone by supplements, but we want to make sure that they're not using supplements that are inhibiting the good treatments we have. And then finally, help patients to avoid the uses that may be detracting from conventional therapies or adverse interactions. So thanks a lot for listening, and I'd be happy to take any questions if there's time.
Dr. Dwyer, do you pick up information in your surveys about people who should be taking supplements but aren't taking them? Like, say they have a condition that requires they take supplements, a deficiency, and aren't taking them?
Oh, that's a very good question. Well, first of all, I don't do any surveys. All I do is sit in the office at the computer and look at what other people did. But sometimes I tell them what to do. But the people who've done a lot of work on that are our colleagues at the Centers for Disease Control. And they got very much interested in women in the periconceptional period, why they were or weren't taking folic acid supplements. And so that's one example. And there may be others that I'm not as familiar with. I'm sure some of our colleagues at some of the other institutes are focusing on that. I know the cancer people have done a lot of surveys on this as well. So yes. Yes.
Thank you very much. I'm very interested in your comments. In pharmacy, we have a huge problem that patients do ask, and we have the opportunity to talk to them about supplement use, but they don't seem to be all that interested in evidence. They're more interested in what their friend uses. You know, those are the experts, not a health professional. So could you guide me to any information relative to how to deal with patients in terms of discussing real evidence with them rather than just relying on friends and family, potentially incorrect information?
Yeah. I think that our colleagues at the National NCIM, National Institute of Complementary and Integrative Medicine, have done some interesting things on that. I don't know if the Time to Talk material is still up on the web, but you can take a look. They've done a lot on that because this is a problem with CAM as well. And so I think that's one good resource. It's a big problem, and I can tell you that the clinical pharmacist is knowledgeable and should be the authority on a lot of these things, and it's unfortunate that people are not listening. Yes.
Thank you. Very good talk. Very interesting. And I'm a pharmacist also, so the last questioner, I can give you some idea of what I do. And also that Time to Talk has been discontinued, and I'm looking for something else like that I need to put in a paper next week. So, but that's not my question. I was looking at your slide number 33, which is licensing hypothesis. And yes, I agree with you that happens. Do you think that is unique to dietary supplements, or in the medication world, the FDA-approved medication world, do patients also think if they're taking, for example, a cholesterol medication, they can eat whatever they want?
Absolutely.
Isn't that rampant through all of our therapies?
Absolutely.
Okay.
Yep. It's a general phenomenon. I think it is. And on the, I wish they'd put Time to Talk back up too.
Please let me know if there's anything else, because I need it soon.
Yeah, well, I go to the help item at NCIM and just ask them. They probably have it someplace that they could send it to you. Yes.
You had mentioned surveys being available for public use to assess supplement use.
That's correct.
Could you provide a few more details or suggestions for where I should look to find those?
Yes. National Center for Health Statistics, National Health and Examination Survey. You can get the whole interview schedule, every item they ask, and for every year they ask. And the same would go for NHIS because they're both under the National Center for Health Statistics.
So I can actually borrow questions
They're
from
public use.
NHANES?
They're public use. You paid for them. You can have them for free.
Great, thank you.
Yeah. And it's a really good resource. They're wonderful people, those people at NCHS. Yes, Dr. Costello.
In talking about the surveys, and we've looked at a number of them, could you talk to the issue that when people look at different surveys and compare how we need to look at the definition that they're using? For
great.
example, multivitamin mineral supplements.
Great question, and something that actually Louisa and Nancy Pottishman and some of the rest of us have been dealing with. We've been looking at surveys, food frequency questionnaires. And what it is when they ask about vitamin mineral supplements, what they're really asking about, or what do they ask about when they ask about supplements. And you'd be surprised, you can't take all of the different surveys that have been done, like the Nurses' Health Study and the various other cohorts, and assume that just because they asked about supplements that they're all asking about the same thing. So the prevalence estimates bounce around a lot. How do you solve that is the bigger question, and I think one way we will be working with others to try to do is to get a uniform definition within government. And then maybe the private sector and some of the academics will come along. But it'd be a lot easier if we all said the same thing was the same thing. Thank you so much for listening.